Hello. We are here to discuss retinal detachment. First, I want to introduce what it is. Retinal detachment is described as an emergency situation in which a thin layer of tissue, which is the retina, at the back of the eye, pulls away from its normal position. Now, the retinal detachment separates the cells from the layer of blood vessels that provide oxygen and nourishment to the eye. So the longer the retinal detachment goes untreated, the greater the risk of permanent vision loss at the affected eye.
The symptoms of retinal detachment itself is painless, but there are also warning signs that almost always appear before it occurs, and these include the sudden appearance of many flutters, which are the tiny specks that seem to drift through the field of vision. Also, flashes of light in one or both eyes.
The diagnosis of retinal detachment. What are the things we can do to diagnose or to know when you have a retinal detachment? The following are the example of the tests, the procedures that can be done. The first one is retinal examination. The doctor may use an instrument with a bright light and special lenses to examine the back of your eyes, including the retina. And this type of device provides a highly detailed view of your whole eye, allowing the doctor to see any retinal holes, tears, or detachments. Another one is ultrasound imaging. Your doctor may use the test if bleeding has occurred in the eye, making it difficult to see the retina.
The treatment of retinal detachment usually requires surgical interventions to repair it, and these include pneumatic retinopathy, whereby the surgeon injects bubble of air or gas into the center part of the eye. If positioned properly, the bubble pushes the area of the retina holes against the wall of the eye, stopping the flow of fluid into the space behind the retina.
Now, the risk factors of retinal detachment. What are the things that can lead or that can prone you to having a retinal detachment? These are the following factors that increases your risk of retinal detachment. The first one is aging. Retinal detachment is more common in people that are over the age of 50 years. Then when there is previous retinal detachment in one eye or both eyes, then when there is family history of retinal detachment, then when there is extreme nearsightedness, which is myopia, and if you have ever done any eye surgery in the past, such as cataract removal, then if there is severe eye injury, maybe you have eye injury or an accident before, then previous or other eye disorder, including retinal schisis or tiny of the peripheral retina, which is lattice degeneration.
Of the treatment, the surgical interventions, indenting the surface of your eye, which has to do with the scleral buckling, when the surgeon sews a piece of silicone material to the whites of the eyes over the affected eyes to hold it, to anchor it. And also, another procedure is the vitrectomy. The vitrectomy, here the surgeon removes the vitreous along with any tissue that is docking on the retina.
2, 3, go. Good morning, everyone. Today, let's talk about the labyrinthitis, which is an ear disorder. So what is labyrinthitis? A labyrinthitis is an inflammation of the labyrinth of the inner ear. Labyrinthitis frequently incapacitates the patient by producing the severe vertigo that lasts for 3 to 5 days. Symptoms gradually subsides at 3 to 6 weeks of period. This disorder is rare, although viral labyrinthitis is often associated with upper respiratory tract infection. So what are the causes? The causes of labyrinthitis is usually occurred or caused by the viral infections. It may be a primary infection, the result of trauma, or a complication of influenza, otitis media, or meningitis. In chronic otitis media, cholesteatoma formation erodes the bone of the labyrinth, allowing bacteria to enter from the middle ear. And also the toxic drug ingestion is another possible cause of labyrinthitis.
Signs and symptoms. Because the inner ear controls both hearing and balance, this infection typically produces severe vertigo with any movement of the head and sensorineural hearing loss. Vertigo begins gradually but peaks within 48 hours, causing loss of balance and falling in the direction of the affected ear. Other associated signs and symptoms, including spontaneous nystagmus with jerking movements of the eye toward the unaffected ear, nausea, vomiting, and giddiness with cholesteatoma, signs of middle ear disease, and with severe bacterial infection, purulent drainage. To minimize symptoms such as giddiness and nystagmus, the patient may assume a characteristic posture, lying on one side of the unaffected ear and looking in the direction of the affected ear. Stop mo muna, boss. Diagnosis. A typical clinical picture and history of upper respiratory tract infection suggests labyrinthitis. Typical diagnostic measures include culture and sensitivity testing to identify the infecting organism. If purulent drainage is present, and audiometric testing. When an infection etiology can't be found, additional testing must be done to rule out a brain lesion or Meniere's disease.
So what is the treatment for labyrinthitis? Symptomatic treatments include bed rest with the head immobilized between pillows, oral medicines, this is to control vertigo, and massive doses of antibiotics to combat diffuse purulent labyrinthitis. Oral fluids can prevent dehydration from vomiting, and for severe nausea and vomiting, IV fluids can be necessary. When conservative management fails, treatment necessitates surgical excision of the cholesteatoma and drainage of the infected areas of the middle and inner ear. Prevention is possible by early, vigorous treatment of predisposing conditions such as otitis media and any local system infection. For special considerations, keep the side rails up to prevent falls. If vomiting is severe, administer an antiemetics, record an intake output, and give IV fluids as necessary. Tell the patient that recovery takes as long as 6 weeks. During this time, he should limit activities that vertigo may be hazardous. If recovery doesn't occur within 4 to 6 weeks, a computed tomographic scan should be performed to rule out the intracranial lesion.